My name is Sohail Patel. I'm an associate professor of radiology at the University of Virginia in the Division of Neuroradiology, and I'm going to be talking about intracranial extraaxial tumors. So the outline of the talk will briefly first describe the anatomy of the extracranial space and imaging signs of extraaxial tumors. Then we'll talk about extraaxial neoplasms and then non-neoplastic extraaxial masses. So the extraaxial space can be considered a few subcompartments. So starting from outside and working our way in, we start with the osseous structures. So in this case, we see a cross-section through the calvarium. Deep to the calvarium is the dura mater, or the pachymeninges, which is a thick meningeal layer that is comprised of two principal layers. The outer dural layer is the periosteal layer that lines the inner aspect of the calvarium and attaches at the sutures. Then there's the inner dural layer, or meningeal layer, and that folds inwards at the interhemispheric falx, the cerebellar tentorium, and the diaphragm ocella. The periosteal and meningeal dural layers split to enclose the dural venous sinuses. Deep to the dura mater, or the pachymeninges, are the leptomeninges. And the leptomeninges are comprised of the arachnoid matter, which lines the inner aspect of the dura, and the pia mater, which covers the surface of the brain. Between the arachnoid matter and the pia mater is the subarachnoid space, which contains cerebrospinal fluid and vessels. Over here, we see schematic diagrams depicting dural or pachymeningeal enhancement etched in white and leptomeningeal enhancement etched in white here in this image. You'll notice that pachymeningeal or dural enhancement is seen as this enhancing area that lines the inner aspect of the calvarium and involves the dural enfoldings, for example, here in the interhemispheric falx. Whereas leptomeningeal enhancement extends over the surface of the brain into the sulci and the fissures and also the cisterns. Pachymeningeal enhancement should be distinguished from leptomeningeal enhancement. So there are various imaging signs that can help distinguish extraaxial masses from intraaxial masses. Usually the distinction is pretty obvious, but especially for large neoplasms or large masses, it can be quite challenging to distinguish whether the mass arises from the brain or from outside the brain. So these are some of the imaging signs that we'll discuss. So this is an example of a meningioma along the left petrous apex and clivus. Meningiomas are the most common intracranial extraaxial masses, and this shows several of the imaging features of an extraaxial mass. First of all, it has a broad dural base. It shows dural tails on either side. At the interface between the mass and the brain, we see a thin cleft of CSF separating the mass from the brain. Okay, so those are all imaging features that identify this as an extraaxial mass. Here's another example of a large frontal convexity meningioma. And in this case, the mass is buckling or compressing the adjacent cortex and white matter, another sign of an extraaxial mass. This is a sagittal T2-weighted image and a coronal T2-weighted image showing a frontal convexity meningioma. And in this case as well, we see a thin cleft of CSF separating the meningioma from the underlying compressed brain. We also see small flow voids representing cortical vessels interposed between the mass and the underlying brain, here and also here. Another sign that this mass is in fact extraaxial mass. Here is a posterior fossa meningioma showing hyperdensity on a non-contrast CT. And we can see that the underlying bone is thickened and sclerotic with a few flecks of intertable ossification extending into the mass. So this is an example of hyperostosis associated with the meningioma. So bony changes are more frequent, distinctly more frequent among extraaxial masses compared with intraaxial masses. Next, we'll describe a series of extraaxial neoplasms, and we'll start with meningioma. Meningiomas comprise 1/3 of all primary intracranial neoplasms. The vast majority are benign WHO grade 1 neoplasms, but grade 2 and grade 3 atypical anaplastic meningiomas do occur. Atypical anaplastic meningiomas are marked by higher recurrence rates and more common brain invasion. Meningiomas arise from arachnoid cap cells. There is a female predominance, and meningiomas occur in middle age. They can occur anywhere intracranially, but most of them are supratentorial. Meningiomas typically have a very slow growth rate, and treatment options include observation, surgery, stereotactic radiosurgery, and in some rare instances, chemotherapy. On imaging, meningiomas are sort of the characteristic extraaxial mass. They're round or lobulated, but sometimes they can have a relatively flat morphology, which is known as en plaque meningioma. And they're typically well circumscribed and sharply demarcated from the underlying brain parenchyma. On CT, they are typically hyperdense. They can calcify in a minority of cases. They show avid contrast enhancement, and they are associated in some cases with underlying parenchymal edema. They can sometimes show a sunburst pattern of vascularity from a dural vascular supply. Dural tails are pretty common with meningiomas and can help distinguish it from other types of intracranial neoplasms, but are not exclusive to meningiomas. Dural tails with meningiomas are thought to represent reactive dural thickening for the most part. Meningiomas can occasionally encase arteries, and when they encase arteries, they can sometimes narrow those arteries that are encased. This is perhaps most relevant in the cavernous sinus, where meningiomas can sometimes encase and narrow the cavernous internal carotid artery. Pituitary adenomas can also sometimes grow into the cavernous sinuses and encase the cavernous ICA, but they rarely narrow the encased ICA. On preoperative imaging, it's very difficult to predict meningioma grade, but generally speaking, grade 2 or grade 3 meningiomas more commonly have less distinct tumor margins. Some oftentimes lack a clear CSF cleft between the tumor and the underlying brain. More commonly are associated with brain edema, bony osteolysis, and have lower ADC values on diffusion-weighted imaging. So here's a very, very typical example of a meningioma in the right middle cranial fossa. It is well circumscribed, uniformly and avidly enhancing. There's a CSF cleft between the mass and the underlying brain parenchyma and a small dural tail. This is an example of a right frontal convexity meningioma here. And we can see the compressed frontal lobe around the meningioma. And we also see that the meningioma is invading the superior sagittal sinus. This is an example of a right cavernous sinus meningioma that's grown along the right cerebellar tentorium. We see hyperostosis on the pre-contrast T1 weighted sequence. These post-contrast T1 weighted sequences show a tuberculum sella anterior clinoid meningioma that is growing along the optic nerve sheath on the left, as noted with this tram track appearance along the optic nerve sheath. These post-contrast coronal sequences show a right-sided tuberculum sella planum sphenoidale meningioma. And what we observe here is ipsilateral expansion of the underlying sphenoid sinus. This is known as pneumosinus dilatans and is occasionally seen with skull base meningiomas. Here is a large frontal convexity meningioma showing avid contrast enhancement and extensive tumoral calcification. Here on a non-contrast CT and on the SWI sequence, this very dark signal. This is another skull base meningioma at the petroclival synchondrosis with cavernous sinus involvement. And we can see that the encased right internal carotid artery flow void is markedly narrowed. This compares to the normal caliber of the contralateral internal carotid artery. Here is an intraosseous meningioma centered on the left greater sphenoid wing. Note the extensive hyperostotic bony reaction of the left greater sphenoid wing. The tumor has extraosseous extension into the lateral left orbit and into the left middle cranial fossa. This is a left frontal convexity meningioma, avidly enhancing on the post-contrast T1 weighted sequence. Interesting thing about this case is that there are very irregular margins along the medial aspect of this meningioma. There's also lack of a CSF cleft in areas along the margin of this meningioma and extensive vasogenic edema. And so this was actually an example of an atypical meningioma, which on pathology showed gross brain invasion. Here is an example of an anaplastic meningioma, grade 3. And in this case, you see this enhancing mass here. The ADC values were very low. And again, low ADC values have been correlated with higher grade meningiomas. We'll next describe solitary fibrous tumors / hemangioperiocytomas. These are dural base masses that can often resemble meningiomas. Solitary fibrous tumors and hemangioperiocytomas were previously considered to be separate entities, but are now understood as probably the same entity, if not overlapping neoplastic entities. Solitary fibrous tumors were typically characterized as low cellular, low-grade neoplasms, whereas hemangioperiocytomas were more commonly higher grade, with greater extent of vascularity and cellularity and higher recurrence rates. But now they're considered a spectrum of mesenchymal neoplasm ranging from WHO grade 1, 2 to 3. They can peak incidence in the 40s. Treatment is with surgery and radiation therapy, and there's a high rate of recurrence and also extracranial metastatic involvement. On imaging, solitary fibrous tumors and hemangioperiocytomas really overlap quite a bit with meningioma. They're hyperdense, they avidly enhance, they're based on the dura. They can have flow voids, they're very vascular neoplasms, and they often have bone invasion. Preoperatively, it can be very challenging to distinguish meningioma from solitary fibrous tumor or hemangioperiocytoma. This is a good example showing just that challenge. So this is a pediatric patient with an extraaxial dural-based mass avidly enhancing along the left cerebellar tentorium. There is a dural tail. The mass severely compresses the cerebral aqueduct and causes obstructive hydrocephalus. Really, there's, I think, no way to distinguish this, which turned out to be a solitary fibrous tumor, from far more common meningioma. So this turned out to be a solitary fibrous tumor, but I think very difficult to distinguish from a meningioma preoperatively. Here is an example of an anaplastic hemangioperiocytoma, grade 3 hemangioperiocytoma. We see this avidly enhancing mass here with multiple peripheral cystic components. We see marked hyperperfusion of the mass, indicating its neovascularity. And really, I think probably the best clue that this is an extraaxial mass or at least began as an extraaxial mass, is this dural-based vascular pedicle. We see along the outer aspect of the mass this little pedicle of vessels kind of extending into the mass. Here on the SWI sequence, we see these arteries coming right from that kind of pedicle there. And really, I think this is probably the best clue that this, it may have started at least as an extraaxial mass, but this was an anaplastic hemangioparasitoma that did invade the brain. We'll move on now to discuss schwannomas. Schwannomas are fairly common benign extraaxial intracranial neoplasms. They are WHO grade 1. They occur most commonly between 40 and 60 years of age. They're slow-growing encapsulated tumors originating from Schwann cells of peripheral nerves. They can arise from any of cranial nerve 3 to 12. They do not arise from the olfactory or optic nerves. 95% of schwannomas are vestibulocochlear nerve in origin, cranial nerve 8. A much smaller percentage arise from the trigeminal nerves, cranial nerve 5, and then 1 to 2% arise from the remaining cranial nerves. There are histopathologic patterns known as Antoni A and Antoni B patterns. The Antoni A pattern indicates a more cellular pattern with denser fascicular organization and correlates with lower signal on T2-weighted imaging. The Antoni B pattern corresponds with a looser tissue organization, myxoid matrix, and lower cellularity, and corresponds with higher signal on T2-weighted imaging. So Antoni A, lower signal on T2-weighted imaging. Antoni B, higher signal on T2-weighted imaging. Vestibulocochlear schwannomas can often present with sensory neural hearing loss, and treatment options include observation, surgery, or stereotactic radiosurgery. On imaging, schwannomas are circumscribed masses. They strongly enhance but often inhomogeneously. Cysts are not uncommonly associated with schwannomas, either intratumoral or peritumoral. They can be associated with hemorrhage, and when they're large enough, they can cause smooth, sharp osseous remodeling. So here's a very typical example on the post-contrast T1-weighted sequence of a right-sided vestibular schwannoma. We see an intracanalicular component within the internal auditory canal extending to the fundus of the internal auditory canal, and a rounded component in the cerebellopontine angle, here as well on a T2-weighted sequence. This is a larger vestibular schwannoma on the left. This large cerebellopontine angle component causes severe brainstem and cerebellar compression, and we can see extension into the internal auditory canal, here again on the T2-weighted sequence. Again, another left-sided vestibular schwannoma. In this case, there is a peritumoral cyst along the inferior aspect of the solid enhancing tumor. So we can see here this non-enhancing cyst, which is T2 hyperintense, adjacent to the enhancing tumor. This is an example of a trigeminal schwannoma, this lobulated circumscribed mass extending from the into the prepontine cistern and the Meckel's cave and cavernous sinus, compressing the internal carotid artery medially. We see again avid enhancement, though inhomogeneous, heterogeneous but predominantly high signal on T2-weighted imaging. This is an example of a jugular foramen schwannoma, of one of the lower cranial nerves, and in this case, we note that the jugular foramen has been smooth and sharply remodeled. So that's a very characteristic appearance of osseous remodeling with a schwannoma, this sharp, smooth remodeling. So when it comes to cerebellopontine angle masses, a common differential diagnosis, the extraaxial CP angle masses, a common differential diagnosis is vestibular schwannoma versus meningioma. And there are several clues that can help differentiate these diagnostic possibilities. Vestibular schwannomas should be centered on the axis of the internal auditory canal. It should, when it can expand the opening of the internal auditory canal, like in this case. Okay. And then, like I mentioned earlier, schwannomas can occasionally have cysts and hemorrhage, which are significantly less common with meningiomas. Meningiomas, on the other hand, are uncommonly centered directly on the axis of the internal auditory canal. They have a much broader dural base with dural tail. They very rarely will actually expand the internal auditory canal, and they can have hyperostosis of the adjacent bone. So those are some of the imaging features that can help distinguish between CP angle masses. Neurofibromatosis type 2 is an autosomal dominant disorder due to a NF2 gene mutation on chromosome 22. It is characterized by multiple schwannomas, meningiomas, and ependymomas. The vast majority of patients with NF2 have bilateral vestibular schwannomas. So this is a patient with NF2. We see on the post-contrast T1 weighted imaging bilateral vestibular schwannomas. These are images through the internal auditory canals, as well as a large right frontal intraosseous meningioma. Okay, so NF2, schwannomas, meningiomas, and ependymomas. Metastatic disease may also involve the intracranial extraaxial compartment. Metastases can involve the skull, the dura, or the leptomeninges. For skull or bony metastases, the most common primary neoplasms are lung, breast, prostate, or renal cancers. For dural metastases, isolated dural metastases, the most common primary neoplasms are breast or prostate cancers. Dural metastatic disease frequently coexists with osseous metastatic disease, and we'll see that in a couple slides. Leptomeningeal metastatic disease occurs in 5% of patients with systemic cancers. Breast cancer followed by small cell lung cancer are the most common extracranial primary neoplasms to cause leptomeningeal metastatic disease. Primary CNS neoplasms can also spread to the leptomeninges. In particular, pediatric neoplasms such as medulloblastoma and germ cell tumors have a predilection for leptomeningeal spread. Glioblastoma in adults rarely can disseminate to the leptomeninges. So this is an example of a patient with neuroblastoma and an osseous metastasis to the left greater sphenoid wing. We can see the bone there's lysis of the involved bone. Tumor has extended into the orbit and into the left middle cranial fossa. This is an example of a patient with breast cancer and metastatic disease. The most obvious finding here is this dural enhancement and thickening we can see over the left cerebral convexity consistent with dural metastatic disease. The patient also has diffuse osseous metastatic disease. On the pre-contrast T1 weighted sequence, we have replacement of the normal hyperintense fatty marrow and patchy heterogeneous enhancement on the post-contrast sequence. So breast cancer patient with dural and diffuse osseous metastatic disease. For comparison, this is the normal appearance of the calvarial marrow space on the T1 weighted sequence, which should be bright on T1 weighted imaging. And this is that patient with low signal indicating diffuse osseous metastatic replacement. This patient has lung cancer with leptomeningeal metastatic disease. And we can see in this patient abnormal enhancement of the trigeminal nerves, abnormal leptomeningeal enhancement overlying the cerebellar folia and within the sulci of the left frontal lobe and right frontal lobe. On the post-contrast FLAIR sequence, we also observe abnormal high signal in the cerebral sulci and overlying the cerebellar folia. Post-contrast FLAIR images give very high diagnostic sensitivity for basically any leptomeningeal process, including leptomeningeal metastases. And on post-contrast T1 weighted imaging, it can be very helpful to look at the cranial nerves and the cerebellar folia surface for evidence of leptomeningeal metastases. Lymphoma can present with intracranial involvement. Intracranial CNS lymphoma can be primary or secondary, which is to say metastatic. Primary CNS lymphoma usually presents with supratentorial intraaxial mass or masses. Secondary or metastatic lymphoma intracranially usually presents with extraaxial involvement, which we'll take a look at here. So these are two examples of secondary intracranial lymphoma. In these two post-contrast T1 weighted images, we see a dural-based lymphomatous mass and also abnormal enhancement and involvement of the overlying calvarium, and actually some scalp involvement as well. This is another patient with a large dural-based lymphomatous mass and compression of the underlying cerebral hemisphere. In this patient with lymphoma, there was a leptomeningeal involvement. In particular, we can see marked thickening and hyperenhancement of the right trigeminal nerve here in the axial image and the coronal image. Granulocytic sarcoma or chloroma represents a myelogenous leukemic mass. They can occur anywhere in the body, including intracranially. Intracranially, they are commonly dural-based masses, but can also involve the bone or the intraaxial compartment as well. Chloromas or granulocytic sarcomas herald the onset of AML or the blastic phase of CML. So this was an example of chloroma in a young patient with leukemia. There was a hyperdense extraaxial dural-based mass. On the non-contrast CT, the hyperdensity likely reflected the high cellularity of this chloroma, and there was diffuse contrast enhancement of this dural-based chloroma as well. You can see that on this non-contrast CT, it can be easy to mistake what proved to be a chloroma for a subdural hematoma. So when there's any question, especially with a suspicious history of leukemia, you'd want to follow this up with post-contrast imaging, preferably with MRI. We'll move on now to skull-based masses. We'll discuss next chordoma and chondrosarcoma. Chordoma arises from notochord remnants. Intracranially, the most common location is the clivus. These are midline clival masses that are locally destructive. They can have calcification within them that represent destroyed bone fragments. On MRI, they're characterized by very high signal on T2 weighted imaging and variable contrast enhancement. Chondrosarcomas, on the other hand, typically arise intracranially at the petroclival synchondrosis, and therefore they are off midline. They have ring-like or arc-like calcifications from mineralization of the chondroid matrix. They have variable signal intensity, especially when there's calcification, but there's usually some areas of high signal on T2 weighted imaging and heterogeneous enhancement as well. So this is a very typical example of chordoma. We see this mass eroding the dorsal clivus with a prominent prepontine component. The mass severely compresses the pons. On T2 weighted imaging, it is very bright here and here. There is inhomogeneous contrast enhancement of the mass. And on the CT, we see flecks of calcification within the mass representing destroyed bone fragments. Also, this is a midline clival mass. On the other hand, this is a chondrosarcoma, and you can note that the epicenter of the mass is off midline, to the left of midline, centered on the left putroclival synchondrosis. We can see these ring-like calcifications throughout the mass, heterogeneous signal on T1 and T2 weighted imaging, and then diffuse but heterogeneous contrast enhancement. So this is a chondrosarcoma. E. chordosis spicillifera is a benign cystic mass arising from the dorsal clivus. Like chordomas, they arise from notochord remnants, but these are benign masses, and the main differentiating feature compared with chordomas is that these really should not show any contrast enhancement. They are often these small masses with small amount of scalloping of the dorsal clivus, and then these prepontine excrescences we can see on the sagittal and axial T2 weighted imaging. No enhancement on the post-contrast T1 weighted sequence. And there's often, but not always, a little stalk that can be ossified that extends into the mass from the clivus. We'll next talk about non-neoplastic extraaxial masses. The most common non-neoplastic extraaxial mass is an arachnoid cyst, and really the key thing to know about arachnoid cysts is that they should follow CSF signal on all MRI sequences, and of course on CT they'll follow CSF density. Epidermoid and dermoid cysts are both ectodermal inclusion cysts. Epidermoids contain keratin debris and show restricted diffusion on the DWI sequence. On FLAIR, they should not suppress, like CSF does suppress. So that's how you differentiate epidermoids from arachnoid cysts. Dermoids, on the other hand, contain not only keratin debris, but also sebaceous material, hair follicles, and lipid. And as such, their imaging appearance can be a little bit more complex. They can have calcification, fat, lipid elements, and striated structures from the hair elements. And they are much more frequently midline compared with epidermoids. When they rupture, they can present with a chemical meningitis. Lipomas are fat density and fat signal intensity. They're often midline, associated with the corpus callosum. They can occasionally calcify, and as such, lipomas and dermoids can occasionally be difficult to differentiate from one another. So here are each of these entities next to each other. In the upper left, this is an example of an epidermoid cyst. We see this T2 hyperintense extraaxial mass compressing the brainstem and the cerebellum. It looks a lot like CSF on the T2 weighted image, but on the diffusion weighted image, there's restricted diffusion, and this is characteristic of an epidermoid. An arachnoid cyst is the next entity we'll take a look at in the lower left here. We see this left middle cranial fossa CSF intensity mass compressing the left temporal lobe. No restricted diffusion, isointense on DWI to CSF. This is a typical arachnoid cyst. In the upper right, we see this complex mass in the suprasellar cistern approximately located at midline. There are high signal foci within the mass on the pre-contrast T1 weighted sequence that suppress with the fat saturation sequence consisted with lipid elements. Also, there's no enhancement on the post-contrast sequence, and then there are these kind of curvilinear striated foci within the mass consistent with hair elements. So this is a dermoid cyst. This, in the lower right, is a pericallosal lipoma. We see that it's T1 hyperintense on T1 weighted imaging, similar to the subcutaneous fat. And there is low density, fat density on the CT scan. You'll notice that it's not uncommon for pericallosal lipomas to be associated with hypogenesis or agenesis of the corpus callosum, and in this case, the splenium has not developed. This is an example of a dermoid cyst that ruptured. So this is a T1 weighted sequence showing a high signal extraaxial mass in the prepontine cistern and right Meckel's cave. And you'll notice that there are small speckled foci of T1 shortening in the overlying the cerebellar hemispheres within the sylvian fissures, and actually also intraventricularly. And interestingly, it lies in the non-dependent portion of the left lateral ventricle, consistent with a lipid droplet. And this is consistent with a ruptured dermoid cyst. Finally, we'll show this mass. So this is a large, round mass in the posterior fossa. It looks like it's extraaxial. We see this thin CSF cleft between the mass and the severely compressed pons. It shows mixed signal on T2-weighted imaging, but quite dark signal around its periphery. And again, mixed signal on the T1-weighted sequence. And so this mass, I think this might pose a diagnostic dilemma, especially if all you have is a non-contrast MRI. But it turned out that this represented a giant aneurysm of the basilar artery. Okay, so I'll just close with this case as a warning. Don't forget about vascular lesions and aneurysms, especially aneurysms and giant aneurysms can present as extraaxial masses and mass-like structures that compress local structures. And if they're first detected on an MRI, the diagnosis of aneurysm just might not come to mind. But always keep this diagnosis in mind, and when in doubt, add it to the differential diagnosis. Consider a CTA or MRA, and this is especially important to think of in the preoperative setting. So in summary, determining whether an intracranial tumor is intraaxial or extraaxial is crucial in forming an appropriate differential diagnosis. We've talked about some signs of extraaxial tumors, including bone involvement, CSF cleft, buckling of the gray-white matter, and compression of cortical vessels. Extraaxial tumors can arise from the skull, the dura, or the leptomeninges. Meningioma and schwannoma are the most common extraaxial intracranial neoplasms. And really, knowing the clinical history is very important, especially knowing whether the patient has a history of malignancy. That would certainly make the possibility of an extraaxial neoplasm being a metastasis much more likely. Thank you very much.